Hi, everyone, and welcome to the Superfeeler podcast. My name is Lori, and I'm super excited today to be joined by Dr. Juveria Zaheer, who is an expert in suicide risk assessment and prevention. So obviously, huge topic for people with BPD and people with strong emotions like us. Dr. Zaheer also focuses on developing targeted suicide screening and prevention strategies, and was named Canada's top 40 under 40, which is so cool, and is an associate professor at the University of Toronto. So random also. She is a huge Jeopardy champion and was all the way to the Tournament of Champions on Jeopardy, and just huge Jeopardy nerd, which I love. so cool. So Juveria, do you want to tell us a little bit about yourself and what got you interested in the suicide work?
Yeah, thank you so much, Lori, for such a warm introduction. So, I've always been interested in people's stories. And I think that suicide is one of the most tragic ends to someone's story. It doesn't only affect the person, it affects their families, their communities, their friends, all of us. And I think beyond that, even living with suicidal thoughts is really stressful and something that often gets sort of wrapped up in risk and other psychiatric illnesses, but people just have a difficult time naming that it is a really stressful thing to happen. And so it's always been something I'm really passionate about. And I am the medical head of the emergency department at the Centre for Addiction and Mental Health in Toronto. And we often see people who are experiencing suicidal thoughts and feelings. And so to be able to provide comfort and support for folks on some of the hardest days of their lives is something that's really meaningful for us. And then on the research side, one thing that has been very clear to me is that you can't try to support people experiencing suicidality without listening to the perspectives of the experts who are people with suicidality. And so on our research team, we are fully integrated with people with lived experience who serve as dual experts. So they have research expertise and they have lived experience. And a lot of the work we do is qualitative, meaning we talk to people who've had suicidal thoughts and who struggled with suicidality about what isn't helpful, what is really helpful. In a perfect world, what does a functioning healthcare system look like? What does a functioning society look like? And how can we best support and advocate?
Such important work, and I feel like as a provider, it must be so frustrating that the system isn't set up to support people.
Absolutely. I think for a long time, one of the troubles that we had is that there wasn't enough awareness that people would suffer in silence and that they wouldn't even be able to acknowledge that they deserve help and hope and care. And I think one of the challenges is that I think that's getting better, especially in the younger generation. I think that people who are under 30 especially are at the forefront of advocating for mental health and getting better mental health care. And I think the challenge becomes is how does the system meet that increased need and increased demand, while understanding two things. One is that a functioning mental health care system should have all of the same resource allocation and evidence-based care that you get in the medical system. So it shouldn't be lessened in any way. But also, at the same time, we have to appreciate that mental health isn't just like any other medical diagnosis. There are things about it that are unique, and trying to build a system that's empathic, affirming, easy to access, and non-traumatic and non-oppressive, I think is really important. And then realizing that mental health care is only one part of the picture. I think suicide prevention requires all of us. It requires access to safe housing. It requires freedom from trauma and oppression. It requires the ability to live a life without feeling scared or feeling worried about your everyday safety. So I think all of those things kind of come together for sure.
Yeah. And so much of your work is around culture and gender too, right? And I think those have such huge impacts on how suicidality is experienced and expressed. I don't know if these stats are accurate anymore, but men die by suicide at a hugely higher rate than women. And yet people with, chronic self-harm, suicidality, that kind of stuff are more likely to be women. Is that still kind of accurate in terms of the research?
And you're exactly right. There is a really big cultural component too. So for a long time in countries like China, women actually died by suicide more than men did, which is really interesting. Although that's sort of leveled up more 1-to-1. But in Canada, men do die by suicide about 3 times more often than women do. But I think too, women have suicidal thoughts, suicidal behavior at a much higher rate than men do, and both are really, really important targets. And I think that sometimes when we talk about these stats, we can discount one over the other, but I think both are so important. And so developing targeted treatment to make sure that people get the care that they need when they need it and how they need it is so important. And I think that the ways in which people are socialized to express emotion, whether it's acceptable to get care or not, the different types of diagnoses folks have, substance use. I think all of these factors are so important in understanding gender. And then culture too, as you said, is such an important piece. So my graduate work was understanding suicide risk in China and Canada. We've done some really meaningful work for our team looking at how to prevent suicide in young Muslims, Muslims under age 30, which is a really sort of interesting and understudied area, and a group of folks that's really important to me as someone who's from that background. And then understanding suicide risk then in folks who have a diagnosis of schizophrenia, who may have similar and different struggles to other folks who have chronic suicidality versus suicidality that comes acutely in sort of a very sort of well demarcated episode of mental illness. Both groups are needing of hope and help, but they may be very different from each other. And so I think a really good system is able to sort of understand suicidality, everything that comes with it, and develop targeted treatments for people so they get what they need.
So what do those targeted treatments look like?
Yeah, so I think it depends on the person. So if you look at something like first episode psychosis, when people develop a psychotic disorder, their early stages at a very high risk for suicide. But if you can give them really good, really supportive wraparound care, like in a first episode psychosis program where you have a case manager, social worker, you have vocational supports, you have a psychiatrist, you have family work that happens, sort of whole person care. Suicide rates in that group who are getting that kind of care are lower than folks with the same diagnosis who don't. So I think that's another really important piece. And we know that for different illnesses, for something, for mood disorders, getting access to care and medication treatment, lithium, for example, is a medication that has anti-suicide properties, which is really interesting for folks with BPD, getting long-term, stable, trusting care rather than kind of short courses of care that make it feel like you can't trust the system to be able to kind of build safety for some folks with BPD. DBT is a really effective and wonderful intervention. Other folks prefer other forms of psychotherapeutic encounters. I think also making sure that people have choice to kind of find the care that is meaningful for them with people they trust is really important.
Absolutely. It's just so hard to find that. Like, I work in the mental health system in BC, and not as a clinician, but I work in patient experience and community engagement. And I talk to patients. They're amazing. I love all of them. They're so cool. And they have so many great insights. And at the end of the day, it's like, well, how do we make this more accessible? Right? Like it's like so great in theory, but from a systems perspective to make it actually accessible for people, it's so hard to actually do that.
Absolutely. And then there's lots of inequities baked in. So if you don't have the money for private therapy, that's an inequity right there. If you are a racialized person and may want a racialized provider and you can't access that, that's another inequity. If you are trans or non-binary and you need and deserve gender affirming care and that's unavailable, that's another inequity. And then, I know that there's a difference between the care you're going to get in Ontario and Timmins and Toronto. And I'm sure there's a huge difference in care that's available in, Vancouver or Victoria or a much smaller community in BC. And so thinking about trying to make sure that the care that you get anywhere in Canada is accessible and equitable is a huge goal, I think, for the system. So one of my mentors, Paul Kurdiak, is the head of the Centre for Excellence for Mental Health Care in Ontario. And one of their big pieces is trying to understand how we can make mental health care like cancer care. So when you have cancer, it's not like people say you can't get care unless you're really, really, really sick. It's like, no, at stage 1, you get the care you need for stage 1. And no matter where you live, you're going to be told where the nearest cancer center is that's going to provide that care. And it's centralized and it's evidence-based and it's accountable. And I think that's where we need to go for mental health care as well.
Absolutely. And
they're like try to beat down 10 different doors to get the care you need, that you go into one door and then the person
they navigate for you.
Exactly.
Yeah. I mean, cancer is such a great example because they're so well funded.
Mm-hmm.
And that I love that idea of like having kind of like cancer centers, like mental health centers that are accessible to everyone. I always think about why things like cancer are so much more, not to say that cancer is not important. Obviously, cancer is very important, but so much better funded and researched than mental health and substance use challenges. And I think I think there's a huge part of the population that still thinks that mental health is like a moral issue and like a pull yourself up by the bootstraps, which gets less funding than like it could happen to anyone. Cancer, which mental health can happen to anyone too.
And even if you look at within cancer, the specific types of cancer,
True.
Like they could happen to anybody, like breast cancer, maybe get more funding than things like lung cancer, which people find that there's some kind of like moral imperative involved, which is absolutely, it's really sad. And I think that we know that suicide is a top 10 cause of death, a top 5 cause of death, a top 2, 3 cause of death for young people. And so if something is such an important cause of morbidity and mortality in society, I think the investment in it is so, so, so important. And I think, even in suicide research, the mental health is far less funded than other types of research, although I do think it's changing and will change. And then even within even within mental health research, suicide prevention tends to be quite understudied for all kinds of reasons. One, suicide is a very complex multifactorial outcome that is, thank goodness, it's rare on a population level. So it's hard to do sort of a randomized controlled trial on how to prevent suicide. There's not generally one cause for people to have suicidal thoughts. There's all kinds of causes. And I think we do not sort of focus on primary prevention enough in suicide prevention, like preventing trauma when it happens, treating early trauma, getting access to care early, I think is so, so, so important. And then I think too, people are afraid to do research with people experiencing suicidality. For a long time, you think about even gender, right? Like for many, many years, women were excluded from all types of medical research. And so for a long time, when you talked about what a heart attack looked like, it was like you have heaviness in your chest, and then your left arm hurts and your jaw hurts. Well, that's what it looks like for men. It may be different for women. And so I think it took in the 90s until women were included in like medical health research. And I think, especially for people experiencing suicidality, I think it is extraordinarily important for them to be involved in research and involved in program development, because otherwise we won't be able to help and support them and get them the care that they need and deserve. And then even when you do research with people with suicidality, sometimes specific diagnoses are excluded. People with borderline personality disorder, people with addictions, and that's not fair. And it's not a way to move forward, I think.
Yeah, absolutely not. And do you think that a lot of that comes, the kind of fear around studying suicide? Obviously, it's a complex issue, but is there a lot of fear from researchers just in terms of like the liability of talking, which is so dumb because the talking about it we know doesn't cause people to die by suicide.
Help, right? And I think I'm just thinking about my own career. It's, suicide prevention has always been something I've been really passionate about. And I was told really early, like it's really hard to do research in this field. Maybe you should do something else. Like it's not easy. And then I think that funding agencies and our research ethics boards, they're so worried about negative outcomes. And so, the thought of doing research with people experiencing suicidality, it's like, what if something happens? What if something bad happens? It's not safe. It's not clean. People tend to want to do research with like one diagnosis, and, like complexity becomes something that we get scared of, because in typical science, you want two groups that are kind of exactly the same, and you have one drug that's different in each group, and you can say, hey, this drug makes a difference, this drug matters. But when people are complicated, though, and I think like it's very rare that you're going to find somebody with one psychiatric diagnosis.
Totally.
And
and they all look different too, right? Even within that diagnosis.
It's very unusual to find someone with just an alcohol use disorder without any comorbid mental health concerns. And so I think that's a really, really big part of it. And I think too, suicide, having suicidal thoughts is like a final common pathway for folks. But I like to think of suicidality as like you would pain or fever. So no one like kind of goes in and is like, I'm going to do a grant on like fever prevention, because fevers come from all kinds of different causes. You can have a fever because you have cancer. You can have a fever because you have an infection. You can have fever because you have an autoimmune condition. Same with pain. You could have pain because you have a broken leg. You could have pain because you have fibromyalgia. You could have pain because you have arthritis. And so I think suicidality is kind of like a symptom. So if we can understand what makes it better, what makes it worse, what makes it, like, how long is it lasting, how intense it is it how frequent it is, and what's the root cause of it? And if we can get at those root causes, I think that's really, really important too, rather than kind of like one size fits all.
Absolutely. And even as a person who lives with kind of chronic suicidality, and I went through I went through a suicide crisis in August and September, and it was way more acute than usual. And even that situation was different than any other situation I've had, right? Yeah. So each like day, moment, person is all going to be different. So you're doing some research on suicide and COVID and the experiences of Canadians. So I actually participated in the research study already. So I totally encourage others to do the same. It's a really easy process. I found it very cathartic to just kind of say everything that I needed to around kind of what my experience was of COVID and how it impacted suicidality. But the state of the world, I think fair to say, is a bit
Scary.
horrifying, scary, doom.
Yeah.
Yeah. Like having like pessimism is like very fair. And so not just COVID, just there's like, climate change, like all sorts of things. How do you see that impacting suicidality in just the general population, in your work in an emergency room? Like, are you seeing a lot of people come in going like, the world is such a messed up place, I can't live here anymore?
Yeah, I think that in general, there's absolutely a lot of reasons to feel distress right now, and distress and pain. I have two daughters, and one of the things that we always tell them is that every feeling is a normal feeling, and every feeling comes from somewhere. And sometimes things will happen in your life that you will feel really sad or scared about, and that is like very, very normal. And then figuring out what you can change and what you can't, and what you want to fight for is so important. But if those feelings ever get to the point where you can't do the things that you want to do that bring you meaning, or you can't enjoy anything in your life, or you may even have thoughts of not wanting to be here anymore, that's an emergency. And so you're exactly right. Having the distress is very normal. But when the distress gets to the point where it is hurting you, and making it hard for you to live the life you want to live, there is help and support out there. And I know it's a tricky line, because of course people are going to feel really sad. But I think you're getting this portion of what's the difference between sadness and hopelessness related to the world versus something that may be modifiable with treatment, or something that putting your, well-being at risk, or something that may be making you not want to do the things that you could do that could help you cope. And I think that's the similarity with COVID, also the similarity with mental illness, is that, people who are like super feelers, people who have had crises, they tend to be really good at knowing what helps them cope. And some things like societal breakdown and stress, or like a pandemic, you can't go to the gym, you can't see friends for dinner. You may, if you have for financial stress, you might not be able to go to the movies with someone you care about. Like there's all these kind of things that get wrapped up and makes it really, really difficult to cope. And that's what we found in our work with the pandemic, is that a lot of the things that people could do normally to support their mental health kind of felt like they were getting taken away. Someone said to me in the study, it's like, I felt okay when it started, because when you have trauma and depression, like you're used to kind of being alone all the time. And it's nice not to have to commute into work. And it's nice that everybody else is like as stressed as I've been for a long time. But then one person said, I thought it was so interesting. It's like, I felt like during the pandemic, I was like cosplaying depression. It's like, I wasn't depressed, but then all of a sudden I was doing all the same behaviors I would do when I was depressed. Like I was home all the time. I wasn't going out. I wasn't exercising. I wasn't really eating right. And it's like those behavioral pieces like kind of made me feel more depressed. And when you are a worrier and then you have all of a sudden all these extra things to worry about, sometimes it can be reassuring because everybody's finally worried like you are. But then sometimes if your brain can't shut off about safety or your physical health or the physical health of those around you. And I think one thing that has come up in our study a lot that was really interesting to me is that there's a lot of conflict during COVID with people that we loved. And so one person in our study said something like, it felt like, everybody who was doing less than you was irresponsible, and everyone who was doing more than you was like unhinged,
paranoid or whatever. Yeah, exactly.
It's like, and really everybody has their own standards and thresholds, but it's really tricky when like it becomes like kind of a value judgment with people. And I think that's another thing that we heard a lot about. And then access to mental health care was something we heard about. Some folks said it was awesome because for the first time I could get virtual care and I didn't have to like drive for an hour and park, and I could like do it in the middle of my meetings. Other people were like, I hated virtual care. Like I didn't know if the person was looking at me or not, or if I was saying the right thing or not. And that was so stressful. And I just missed like getting out of the house and seeing my therapist. So it's really, really interesting. I think everybody's experiences are very different, and our goal is to sort of understand them and harness the things that we can do to build a better system for people if it ever happens again. But also a lot of the stressors that came with COVID are stressors that still exist. And so how we can best support people through that.
Yeah, definitely need to like take COVID as a lesson for a lot of things.
Absolutely.
And there are positives for sure. Like that access to care virtually makes such a huge difference for a lot of people. I know there were so many people that were coming to my peer support group that I started during COVID that's virtual.
Amazing.
And going like, I never would go to group if it was in person, ever. And now they're going to virtual group. And then eventually they felt comfortable going to virtual group therapy. And then, right. And it just kind of slowly allowed for more people to be able to participate in the world. And I mean, I think like work from home is such a great thing that more people should be able to do. And there's, there's a lot of positives for sure, but it's definitely hard to have hope for the future just as a general concept, I feel like. And I don't think that's just like me having chronic suicidality saying that. I think that's just like, I think we see that in like birth rates and a whole bunch of stuff where people are just kind of like, is it worth it? I don't know. Is the world going to still be here?
It's hard. And I think when you look at generationally, this is the hardest generation it is to buy a house. It's the hardest generation is to get a job out of school. The worries about climate, the worries about social injustice and inequality. And so it's really, really hard. And at the same time, for me as a woman of color, I have more opportunities now than I would have had 20 or 30 years ago. At the same time, I'm really worried for my children. And there's so much gray, I think, in trying to understand the world. And so, trying to figure out like how not to feel so crushed by the weight of what's happening in the world right now, and how to sort of say, my feelings are really valid. And a lot of people are feeling the same way, and to connect with folks feeling the same way and saying, okay, what is the one thing that I am going to change? For some people, it might just be, how am I going to keep myself safe and how I'm going to build a life with meaning. For other people, it might be, this is one issue that I care very deeply about. How am I going to invest time into that issue? So there's like different ways, I think, to manage. I think that in general, in my experience, talking to folks, especially in the emergent and suicidal crisis, I think that absolutely the world around you can impact your sense of safety and your experiences and your suicidality. One of the things that I kind of, the example that I use as an Indian person, it happens less frequently to me, but I don't know if you've ever had a sunburn in your life.
I have many, yes. As a very white person, that happens to me often. Yeah.
I had my first sunburn when I went to the Dominican when I was in my early 20s. And I was like, why does the water hurt my skin? Like, what is happening?
Yeah.
Like, if I put on a shirt, it hurts. And I think that living with BPD, living with major depressive disorder, alcohol use disorder, it's like living your life with second degree burns, right? It's like the things that you see in the media, or like conflict with family or friends, or just life stressors, rather than like just feeling like a shower. It feels like your skin is peeling off. The pain becomes so high and so hard. And so what I would say is that treating mental illness then and giving people the support they need can help make those very, very real stressors just hurt less, and to feel better equipped to cope with them. And I think that's kind of like the top down and bottom up piece. For sure.
Mm-hmm. Yeah, it's like putting aloe vera on those sunburns. I really like that.
Yeah,
that's genius. I'm so curious. Actually, no. Let's keep going on the study for a second, and then I'll have other questions. So I know that you're looking to recruit like specific groups of people at this point. So it's all across all of Canada, right?
Well, our study is taking place in 4 provinces. So British Columbia, Manitoba, Ontario, and Nova Scotia. Because I'm in Ontario, the Ontario recruitment has gone really, really well. Just because I have, no folks and no networks, but the other 3 provinces we're really, really excited about. So if you're listening from one of those 3 provinces and you experience any suicidality in the 6 months before the pandemic or during the pandemic, so 2020, 2021, 2022, we'd love to talk to you. In general, in qualitative research, it's a little bit harder to interview male identifying folks, just because, historically, I think women, non-binary people are better at are so
talking about their stuff. Yeah.
This kind of stuff. So I think that we'd love to speak with both women and men, but especially men and non-binary people if we can. And then we want all kinds of folks who have all kinds of different diagnoses too. So, you just don't have to have one or another. Like any kind of diagnosis is good. Substance use is good. Whatever makes you you. And then the other group that we're really interested in recruiting for, it's a bit tricky. It's like people who are over 65. So a lot of the more traditional ways of recruiting for research are a little bit tougher with people over 65. And so if you have a loved one who's over 65, we think would benefit from just talking about what they went through. That's another really important group for us. But we're interested in everybody, in all, everybody who has experienced something like this. If you live in rural areas, we're really interested because your experience, again, if you're living rurally, is going to be really, really different. So we're really interested in hearing from you for sure.
Yeah, and it's a pretty easy process. I think there's like a couple of Zoom calls with your team just to make sure
Cool.
that you're like eligible, and then
Yeah.
I think an online survey if I remember
And
correctly,
online
and then
survey just
just
so we can get to know you in terms of like your lived experience, like your diagnoses, your education level, how you identify in terms of gender and race and that kind of thing, your service utilization history. And so we like to get that all over with. So then when we interview you, it's actually much more like conversational and you can tell a story
yeah.
rather than being like, what are your diagnoses? Yeah, people tend to really enjoy the interview process. The other important thing for us is that there is compensation for participating in the study because it is, I think it's $40. I'm not 100% sure. I'll double check
That sounds right. Yeah.
because, and we'll fund it to you where you are because, giving the time to do this kind of work, it's a lot of emotional labor for you. And so we really want to make sure people are compensated for their time, usually lasts about an hour. And then the benefit is that the work we're doing, we've already done about 85 interviews, I think, and we're
Mm.
hoping to get to 100. So we're kind of on that home stretch. So if we can get these done, then we can publish the work and leverage the work to improve care and to do more research on this topic, which I think is really important. And if be able to sort of build guardrails and guidelines and recommendations to provide support for people across the country.
That's so cool. Yeah, I've definitely sent it out to a bunch of people already, and I'll include the information in the show notes as well, so people can sign up if they're interested. Are you able to talk about any like preliminary findings that you have?
Absolutely. So, we've done a lot of analysis with the findings for young folks, and one of the things we found is that that the the pandemic represented like a seismic shift in how people's lives were going to go. For someone like me in my like early 40s, yeah, it was awful. I had kids at home, and I was working in an emergency department.
Yeah.
You know, those 6 months or a year of major changes is like a small portion of my life. But for young people who are in university trying to get their first job, like that represents a huge shift for them. And so people often talked about how in the early stages of the pandemic, the first few months they actually felt okay, felt maybe a little bit better because a lot of the stresses from life were kind of taken away. But then as those stresses build up, so for some people, like having loved ones who are working in unsafe areas, like during the pandemic, other folks who have disabilities who are really worried about their own health and, felt feeling really isolated from their friends and family, people who were really, really high functioning, like loved going to school, felt like failures for not being able to go to school, people who were supposed to go to university who weren't able to and were stuck in their rooms, people who have, trauma and conflict with families, being stuck living with their families. Like there's one person who said something really beautiful. It's like, it's very different to isolate in a 6-bedroom like lake house than it is in a 2-bedroom apartment with your 4 siblings. Like it's very, very different. And so then we talked a lot about too, like access to healthcare. Some of the things you talked about, Lori, like how can I live in a world like this? Like, what if there's like a food crisis? Like, are things ever going to get better? That came up quite a bit. And then one of the really cool things I think about the study is that recovery was very different for different people. So for some people, it was around getting psychotherapeutic support. For some people, it was time. A lot of people did a lot of their own research. Medication was really helpful for a lot of people who wouldn't even consider medication before. That was one part of their recovery. And one of the things I thought was really cool is that two things. It's like one, they didn't want recovery to mean going back to the person they were before the pandemic. To them, recovery was much more transformational. It was like, how am I going to be something better and different? How's the world going to be better and different after this? COVID was this huge shared trauma that everyone had. And like now, finally, the whole world understands trauma.
Yeah.
The whole world understands mental health in a way that I think wasn't the case before. So they were really passionate about transforming mental health care, access, choice, and then things like, thinking about financial security and thinking about equity. Like these kids, the young people were like really pushing towards a more equitable society, which I thought was really, really cool. And then, people just saw themselves differently as well after the process. And some people, it was hard. Some people said, I'm less hopeful, less enthusiastic than I used to be, more guarded, more jaded. Other people said, I feel stronger. I have better boundaries. I know myself better. So I think it sort of depends on the person. But I think the idea of COVID as transformational, COVID as a way that people with pre-existing mental illness may like lose a lot of their abilities to cope. And people who've never really had suicidality before were experiencing everything for the first time. And that was really, really frightening. I think for people with pre-existing mental illness, it's a little bit easier to say like, oh, this is like a huge stressor for me. Like, of course I'm stressed. For people who've never had it before, it was like, what the hell is going on?
Right.
Why do I feel like this? I don't understand. And so it's sort of neat to see the different trajectories for sure.
Yeah, and they may not have the coping mechanisms, right? Where like I've had BPD my whole life, and so I'm able to like it was awful. Don't get me wrong. Like I had a lot of bad moments,
Well,
but being able to be like, okay, I'm going to use my
yeah, you
DBT
have a safety
skills to like,
plan. You have a playbook.
yeah,
Yeah, for sure.
totally. And the lack of like not lack of, less self stigma around medication use and that kind of stuff, because you've been on them for so long that it's,
Exactly.
you
It's not
kind
like
of know
no
what's going to work, what's not.
exactly. That's exactly right. And I think in some ways, folks with pre-existing mental illness, sometimes people said like, so to me once, I think one of the interviews, it's like, this was like not the worst year of my life by far.
Right.
Like saying
Yeah.
like, there's like so much, like, I hate the word resilience sometimes because like no one should have to go through trauma and distress so they can be resilient. Like, I don't like that
Right.
word, but there is something to be said about like having the expertise to manage this kind of stuff in a way that maybe other people don't, which I think is really, really interesting.
Yeah, so interesting. And did suicide rates in the end go up during COVID?
So it's a great question. So there's some really great research that's happened across the world, like sort of ongoing living systematic reviews of suicide rates. So I think initially suicide was sort of used as this kind of political kind of tool.
Yeah.
Everybody at the beginning was like, well, if you close schools, people are going to have suicidality. Then other people were like, oh, like if you close down the economy, people will be more suicidal. Then would be like, oh, if you make people go to work, they're going to be, and it's like different like political groups, I think we're kind of using suicidality as this, but like really you got to look at the facts. And we know that historically in times of large global crisis, like the world wars, suicide rates tend to go down a little bit initially because there's a sense of like everybody's in it together and like, we're kind of together. And so what you saw, I think around the world, we didn't see a significant increase in suicide rates, maybe a little bit of a decrease in the first few months. But distress was still quite high. So there was still lots of like suicidal thoughts, like increased distress, like people were reporting more suicidality, but not less, not, you didn't see that in death rates. But then there was these signals of like higher risk groups. So, African-American men in the United States, women in Japan, there was these young people, these like sort of signals that things were hard. And I think the other thing to remember too is that sometimes like being in a crisis mode is like really hard and scary, but reintegration is harder. So I think what you end up seeing is that a lot of people have much more distress when instead of being full-time virtual, they need to go back 5 days a week to work. And that becomes like a huge stressor. Teachers and healthcare providers, kids, like that is another piece. So sometimes the risk doesn't come right away. And I think the psychosocial and psychological impacts of COVID are going to take a decade to understand, rather than kind of just in the moment, like year over year, for sure.
Well, absolutely. I see my niece and nephew are 5 and 3.
Oh my gosh.
And like one was born late February 2020.
Oh my gosh.
Like, so I just remember like thinking like, oh my God, what are you going to do with this child? And then also now seeing them interact with people in a very different way than a 6 or 7-year-old interacts with people, because they didn't have 4 years of like human interaction with strangers. It's wild.
My youngest is just turned 7. So she was 2 when this started. And before the pandemic, she's so outgoing and so chatty and like loved everything. And then, when as things have rolled out, she's much shyer, a little bit more anxious in loud groups, like more anxious with noise. And she can't name it. Like she can't be like, there was
of course
a pandemic.
Not.
So
yeah.
But it's really, really interesting to see what that looks like. Where my big girl always around large groups of people, like family events, social events. And, she was 6 when it started. So she kind of had a personality and a life before the pandemic. And I remember my little girl said recently, oh, Mom, I don't remember what it was like before. And how could she? Just like you're not, like, how could he? Like it's their life.
Yeah. Yeah. And I mean, it's honestly, it feels like everything in the world now is like a pre-COVID or a post-COVID.
Exactly.
Like there's no world that is like, it doesn't matter if COVID happened before or not. It's like everything is contextualized by whether or not it was before or after COVID.
Absolutely. Or during.
And I think that'll be forever. Or during, yeah. I mean, yeah, I'm always like, are we over COVID yet? I'm still not sure.
Another really important point is people are still getting COVID and people are still getting COVID. And we haven't even talked about long COVID. And that's something that's
yes. Oh my gosh.
Too. And how distressing and awful that is when it feels like the world is moving on and you're still stressed. And for people who are immunocompromised, everybody's like, yay, like no mask, like we're having fun. But like people are still afraid of getting COVID and many people should be. Like it is still, there still are those stressors that exist. And that's a really, really interesting point. And we went through it in our study. It's like in the beginning when we started recruiting, it was 2022. And it was like, well, still COVID. But then like, what is the end of COVID? You don't know.
Yeah.
And it's hard to know.
Totally. The long COVID thing's such a good point because it impacts people forever, and we don't know what the long-term outcome of that is going to be.
Yeah, and how it
It's
affects
so
you.
scary.
Yeah, for sure. And people's experiences of that can be very, very frightening. And then I think it's sort of in any kind of like post-viral autoimmune kind of condition, sometimes our system isn't really set up to support those folks at the best of times. So it can be really hard. And I think it can be triggering too. Like it can bring back hard memories for people about like having difficulty accessing care in the first place, or experiences of depression or anxiety in the first place, for sure.
Mm-hmm. Absolutely. So is there any provincial differences that you're noticing in the research?
Yeah, that's a great question. So now we have our 4 provinces, like our Ontario data is pretty well collected. To be honest, I haven't seen anything just yet. We do see differences, like more even not between provinces, but within provinces, urban, rural. So
that makes sense
to be a little bit more consistent. But I haven't seen many differences in what the narratives are in folks from BC, Manitoba, Nova Scotia. Actually, you know what? I shouldn't say that. The Nova Scotia interviews are a little bit different, I will say. So I think that things were a little bit different there, especially early in the pandemic on the East Coast. But I think the other 3 provinces are pretty consistent, for sure.
That's interesting, because I feel like the response from Toronto or from Ontario, BC, and Manitoba were probably very different. I don't even know what Nova Scotia's response was, but just in terms of how it was kind of used politically and stuff. Okay, I have 2 very random questions for you. So you mentioned earlier lithium and how it has impacts on suicidality. Can you explain the why?
Yeah, it's a great question. And, any type of psychiatric treatment that helps an illness is going to reduce suicide risk, especially anything that helps a substance use disorder will reduce suicide risk. But there's some medications that are really interesting. So clozapine is one for schizophrenia, where like kind of individually, there might be some kind of anti-suicide effect to the particular medication. And lithium historically has been associated with lower rates of suicide in mood disorders. And it's, people say that it may reduce a little bit of impulsivity. It make people feel a little bit more settled. It's unclear what the mechanism is, but sometimes you see it in like, if there's communities with more lithium in the water, like that community may have a lower suicide rate than other communities.
Interesting.
But lithium is like it can be a tricky medication for folks to use. And I think with any medication, and we've done a lot of research with patients or service users or whatever people prefer. And like one of the really important things about medication is that people feel most empowered when they are making the choice and they feel like it's a good dose for them. And if people are getting like really tough side effects, then it might not be the right choice. But lithium, at the appropriate dose where it's not causing awful side effects for folks, can have some protection against suicide risk. For sure, ECT is another intervention that can help, help with suicide risk too, or like acute suicidality.
I saw you've done some research on ECT, electroconvulsive therapy.
A long time ago. Yeah. It was one of the first kinds of research I ever did. And it was very cool, like looking at ECT, maintenance ECT, and other treatments called TMS, like transcranial magnetic stimulation, which can work really beautifully for some folks. And I think making sure that people have different options, and that like in a perfect world, we'd be able to to meet someone and do targeted treatment and say, I think this is actually going to work for you first. And I think we're going to get eventually where it's like, this is the right medication for you based on X, Y, or Z. And sometimes it is trial and error. You may end up going through, the big studies suggest that for people with depression, 1/3 of people will respond and remit with the first drug. And another third of people will remit with
1/3. Wow.
With a switch. So then, say if I'm on sertraline, it didn't help. If I switch to Effexor, another third of people are going to remit. And then there's a third of people who are a little bit trickier, who may need, 2 medications, or may need, brain stimulation, may need psychotherapy, or may need something else. I think always it's people are individuals, and not all treatments are created equal, but to make sure that you're working with a provider that listens to you and that you feel engaged with, and that you're measuring your symptoms with I think sometimes in psychiatry, we don't do enough measurement-based care.
Right.
And I think we never want to reduce people to checklists, but I think knowing what your symptom load is at each and every dose change and each and every medication is like super, super helpful, because that way you will be able to like not just be 40% better, like you want to get 100% better. And so figuring out that with time, I think can be really effective. And there's some good research in that area.
That's really cool. I don't feel like I've had enough access to psychiatry, to be honest, to have anybody do that level of like kind of investigation.
Yeah, and physicians can do measurement-based care, and even one of the things that you can do on your own. But I agree, like I think that's a huge issue, and I think for folks like even like PHQ-9s or JD7s, like monitoring your own symptoms and to be able to say to your provider, like, yeah, my symptoms are 20% better than last week. It can be helpful to know like where to go next. And of course, it's one piece of your care, but just like when and like the experience, the narrative, and working with someone is really, really important. But you wouldn't try to treat your blood pressure without measuring your blood pressure, I think.
Totally. Yeah, good point.
Measuring your blood sugar. So I'm a big believer in measurement-based care and psychiatry, if we can get there in a way that is
like still person-centered and
personalized. Yeah. And we've written some papers in that area about how you can make measurement. And it's so interesting. We did a study once with folks with schizophrenia, and like the care providers were like, patients don't like scales. They hate them. It's a waste of time. And the patients are like, we love these scales. I like to know like how I am in comparison with myself last week. And so it's so cool to see how people's perspectives can be different.
And this is why it's so important to have patients involved in research.
100%. Absolutely.
Yeah. Because, sometimes I've seen some research around BPD in the past where I'm like, you clearly did not have a person with lived experience read this question. And I'm the annoying, I mean, sometimes I think that they think it's helpful, but I always try and participate in research because I think it's really important. Yeah. And I'm always the person who's like, okay, completed that survey. FYI, question 2, 7, and 15 should maybe be considered to be reworded.
And I think, what is another really important point too, is that if you can involve patients or people with experience or dual expertise at the front end, then, Lori doing the study doesn't have to be like, yo, this is like really
exactly.
And the other thing that sometimes we think about a lot in our research team, and Gina Nickel is my, co-lead on this project, and she's a person with dual expertise and she's brilliant. She often says that, like when she helps write the protocols and she can review everything as it goes. And one of the things she and I talked about a lot is that sometimes patients are used as like consultants. It's like, here's some money and you can kind of read this over later and decide if you like it or not. But one of the things we really stress on our team is patient partners, dual expertise researchers as full and equal members of the study team. So being paid a living wage, being able to live a dignified life, not having to like hustle to have 3 different jobs, like being able to like be on grants, being able to be for software and publications. Like I think that's really, really important. That full integration. Yeah. So you don't end up in that position where the participant is reading it and being like, this is like,
I know,
not good.
Truly. Well, I just interviewed Dr. Amanda Ulizik from University of Toronto too, and she does a lot of patient engagement in her research too. And I was like, man, University of Toronto's seemingly where it's at. I don't know, maybe I'm like actively like considering PhD programs, and I was like, well, I wasn't gonna go to Toronto, but maybe I should.
Yeah, the whole social work has been really, really at the forefront of this work in Toronto. And another place where this happens a lot is the UK, where they've been places like big journals like the Lancet. They won't like take your paper to review unless you've had meaningful engagement with people with experience, which I think is really cool.
Yeah, like, and that's how you have to do it, right? Because otherwise people will just not bother.
Exactly.
And that word meaningful is so important, right? Because you can have like checkbox engagement.
For sure.
Okay, so that's my one random question. My second random question that you may or may not want to answer. In terms of suicide and the Canadian context, in the future, presumably, we'll have medical assistance in dying for people with mental health issues. Has that come up at all in your research in terms of what that would look like and what perspectives are on that?
It's not my, there are many people, bioethicists, other psychiatrists, patient advocates who are really, really strong in this area. It's not my main area of expertise by any means, but I am a human being, and I am a person who works with patients, and a person who cares deeply about suicidality, and a person who cares deeply about people being able to have dignity in all parts of their life, including in death. And so one of the things that I think about with MAID, which is something in general that I really believe in for many diagnoses, is that when you look at folks, maybe we'll say, geriatric patients, for example, who die with MAID versus who die by suicide, their demographics and their symptoms and the way that they express distress is very different. And so my kind of orientation around it is if someone's having suicidal ideation, then they deserve to get all of the hope and help and care that's available to them to make sure that, many of these pieces can be helped with hope and help and care. And my worry would be that you never want to have an option that circumvents all of the hope and help and care somebody deserves and needs. Right. And I think that that's really, really important. And I think that anything like MAID needs to be, very well demarcated and well protocolized. So, mental health care providers can work with you and walk with you at every step of the way to make sure that everything is done. So you make an ethical and meaningful decision. There's a big difference between, jumping out of a building that's on fire.
Yeah.
And deciding on a dignified end of life. They're very different. And so I think making sure that people are in the place where they feel empowered, that their symptoms are managed, that their pain is managed before starting the process of making the decision for me, I think is important. I hope that's not a cop-out.
No, not at all. I think it's such a complicated question that I mean, I'm a huge firm believer in MAID. I've had many family members use MAID, and it's the most beautiful way to die. I wish it for everyone.
But I hope too that people with mental illness though get the care that they need.
That's the thing. Is I so personally think that MAID should exist for everyone. But it's not used as a the system doesn't have the supports that I need, and therefore I'm going to die instead. It's I've tried all of the supports that I need, and I've been offered those supports in a free and accessible way, and I still want this choice a year later. That those are the caveats
with time and space and kind of ethical approach and ethical assessment.
Yeah. But I think it's it'll be a really interesting topic in the next 10 years of suicide research in Canada, because this is going to be something that comes up. Okay. Anything that we didn't talk about that you really wanted to talk about today?
No, this was so great. It's such a wonderful way to spend an afternoon. And I'm so, I think the work that you do is so, so important. And it really makes me so happy to know that podcasts like this exist so people can not feel alone in how they feel. And you can look at super feeling as a superpower rather than as something to be ashamed of or scared of. And there are many people in healthcare who end up here because they have lived experience. And there are many people who are profoundly empathic and kind because they've lived through all kinds of hard stuff or are living through hard stuff. And I also really appreciated that you talked about your own experience of suicidality even recently, so people can see you and say, oh, there's a person who's amazing and has it together, and she can suffer too, and she can come through.
Totally.
And I can suffer and I can come through. And I think that's really, really beautiful.
Thank you so much. Yeah, it's been so great getting to know you, and even your team that's doing this research have been so lovely. So my last question that I always ask is what your favorite part of working with people with borderline is.
Yeah. I've always loved this population. I love emergency work because I get to see folks who have BPD and who have chronic PTSD. I think that when you have a lot of trauma, or you have heightened emotions, you're very aware of everything. You're so good at picking up on small cues. You're so good at kind of clocking what's happening in an intervention. And so I always it's going to sound really silly, but I always have had a lot of laughs with folks with BPD. Because, in the moment, when you can support someone and empathize and show them that you care and that you're listening and you can work together, just some of the things that folks say, because they're so observant and totally clock everything that's happening. I find humor to be a really useful tool. Sometimes it's very dark humor, but humor.
That's how you got to do it.
Yeah. And I think too, one of the things that I love is that historically people with BPD, even for 200, 300 years, however you conceptualize it, there's such a gendered aspect. It's so awful. It's a way of refusing care for folks. I think that's really changing. Even in I graduated from medical school in 2007. I've seen such a sea change in people wanting to work with this population, people feeling proud of their diagnosis, having treatments available. And one of the really cool things that I love is when I see people who are in crisis, I always like to ask them about what their life is other than in this moment right now. To be able to see, the beautiful things people can do and accomplish, and that they may look different when they feel like they're in crisis, and that there are things that we can do to help them, to support them, and that they can do for themselves and we can do together as a system to help, I think is so, so meaningful. I'm a big feelings person too. So I would talk to someone all day who has big feelings rather than someone who doesn't think feelings matter or feelings are important.
Thank you so much for that answer. That is so well said. And I'm glad that you like talking to us and you like our dark humor, because we certainly have that.
You have to laugh.
Yeah, exactly. Truly. Absolutely. Awesome. Well, thank you so much, Juveria. Thank you so much for listening to the Super Feeler podcast. This episode was recorded on the traditional and unceded territory of the Matsqui and Sumas First Nations. If you'd like to learn more about the Superfeeler podcast, share your story, or participate in the Superfeelers Club, which is our peer support group, it's totally free, virtual, and open to anyone who experiences intense emotions or has borderline personality disorder, please check out the link in our show notes or go to laurieedmondson.com. If you would like to support the show, we would very much appreciate it. There's an option to do monthly small donations at whatever denomination you'd like, and you get bonus content, extra resources, and extra connection to me throughout. That can be found on patreon.com/superfeeler, or again in the notes below. Thanks again, and have a great day.